Great. Well, thanks to Steve and Wendy and Kim. We are actually going to, you guys are going to go back. We're going to get the panels up here. You will have an opportunity to answer questions at the end. So,
At the end?
yep. So just be ready for that. So we've got a couple panelists that could come up. Adrian, we've got Noah, Josh, and John, whom I do not know. John, great. Nice to meet you. Okay, one thing I didn't say, but I think everybody probably saw it. The bio packets, the summary, some background is out on the table. So make sure you pick that up because we unfortunately didn't have time to kind of go through everybody's bio. But clearly there's some really rich participants here. So please take that opportunity to look at bios. So now these guys have a challenge because they have 5 minutes and 5 minutes only to really sort of reflect on what's been shared in this session 2. So Noah's going to start, and Noah Kraft is from Science 37. We have Adrian Hernandez from Duke, and then John White from Health and Human Services, and Josh Rose at the very end is going to finish up the panel from IQVIA. So 5 minutes, Noah.
Great. Thanks for inviting me. It's a pleasure and truly an honor to be here among such great giants. I can't help coming to Washington and think about the notorious RBG, which I just watched last week, Ruth Bader Ginsburg. And I'm going to have to paraphrase because I can't get her quote just right, but in her arc of history and how she sought to impact change for women's rights and a lot of social rights, she described her intention as, if you believe in this really potent arc of change, you're going to get knocked down and you're going to have to invest and be methodical and relentless and tireless and persistent. And I believe that this change, the dramatic change we're trying to make in this room, shifting from doing things around doctors to doing things for and around patients is not going to be easy, and it's going to require relentless, tireless, getting knocked down, challenges, getting back up. But I believe that we're all here for that kind of intent, and I think that the impact, not just for science, but for patients, will be profound, and discoveries will be dramatically shifted to be more potent. That said, with my remaining 3 minutes, I'm a recovering academic physician scientist. 4.5 years ago, I was at a conference before we started our company. I met Craig and I met Ray Dorsey, and I said, if these quacks can do this, I can do this too. So they described what their experience had been to date, and actually, Steve may not know this, but right around that time, I was introduced to the innovation group at Genentech because my history had involved doing clinical trials myself, starting a private telemedicine company before telemedicine had come of age, and then I became the chief medical officer for an enterprise software company integrating with EMRs before EMRs had come along. So I had this experience in trials, telemedicine, and software. And I got introduced to the innovation group at Genentech, I think after Steve had been working with them. And their challenge to me was, can you help solve this problem, that clinical trials are too slow, too expensive, and not great for patients? So we set out to do that. And when we looked around, we asked, could universities do this? Could technology companies do it? Could CROs do it? And we decided we better start a new company to do it. That company, I'm not here to talk about that, but what we did was put together an end-to-end system that could replicate parts of what the current system do, but in a wildly different way. So we put doctors, technology, telemedicine, and most importantly, a direct-to-patient approach to clinical trials into that. And so the things that struck me, that's what we've been doing, and we've done about 20 projects to date, some of them complete phase 2B programs, completely virtual. I was inspired to hear more and more about the things that have been done by Ray, by Steve, by other giants in the field. And the main message I'm hearing is that it is not impossible. Meeting with Leonard Sachs from the FDA last month, his message, I'm going to paraphrase this too, is there's nothing new here, people. You've done all this in different pieces all together, and let's get on with it. This is all doable, and as Ray Dorsey pointed out, it requires only courage and drive, and it's really up to us to push past that. Our company's worked with many of you. I think to Kim's point and to many other people's point in here is we have to design these projects and these trials for fit. They have to be designed for the patients, but they have to be simplified, and you have to be very specific about what you're asking. If I can say one thing is the challenges of what we've done so far have been hamstrung by the complexity of the trials and retrofitting what you think you can do in a site into a patient's home, and it just drives the thing into the ground. And I've heard that many times from several different presenters today. The last thing, just in closing, I want to try to stick to 5 minutes, is related to, I think, some of the things Steve Cummings was saying, but we at our company, we call it the science of science. And that is, they're twofold. One is the methodologies of directly engaging with patients for recruitment, behavioral change, getting doctors and people to do things differently. It's been written about by Daniel Kahneman and many others as behavior economics. But the science of how you get patients to be engaged and sign up for things that they don't want to do is a wild experience, and we have to get better at documenting how that happens. It plays into my final point, which is when you hear about the 3 or the 4 trials that have been done, or the 1 trial that have been done, you can never look at it as a failure, and you can never extrapolate from that N of 1. Like Steve was saying, maybe digital recruitment is not good for this trial coming up, not the aspirin one, but the fracture one. We've done about 20 projects now, and in some of them, Google AdWords were exceptionally effective for rare deadly disease diagnosed in midlife. In others, in mild acne, Facebook recruitment was exceptionally powerful. You could randomize a patient for $128. And in other trials, it costs $50,000 to randomize a patient with digital recruitment. So trying to extrapolate from any one of these lessons, one trial, is probably a bad idea. As a scientist, we have to be making observations, documenting very carefully how we've been doing things, and really committing to the long arc of history here. I think most of the people here are committed. If you weren't, you wouldn't still be here. A lot of people have been working on this for decades now. I'm new to it, so those are my observations.
Thank you, Noah.